Hi everyone, and welcome wherever you are across Australia, New Zealand, and indeed around the world. We're delighted to have you with us. My name is Brett Ayres, and on behalf of the Canon Medical team, it's my pleasure to welcome you to tonight's webinar. And it's on expert insights into dense breast imaging, and it's presented by Professor Mary Rickard. Professor Rickard is a highly respected breast imaging radiologist based in New South Wales, and she's a renowned expert in the field. So tonight she'll be delivering a live presentation, followed by a live Q&A session. For this live event, CPD will be available for those who remain logged in for at least 40 minutes of the webinar. While attendees are still logging in, I just thought I'd briefly highlight a few Canon Medical supported educational activities coming up this year. In 2026, Canon Medical are proud platinum sponsors of the ASA, and this includes ASA 2026 on the Gold Coast. This year, we've already delivered workshops in Perth, Wollongong, and we've also got another travelling workshop coming up Saturday week on the 28th in Cairns, and it's led by Paula King and it's focused on general ultrasound. And then later in May, as a lot of people will know, we'll be at the ASA 2026 on the Gold Coast, where we'll be hosting Friday and Saturday lunch and learn sessions, along with a full program of workshops in our sponsored room. This coming Saturday, so just in a couple of days' time, we're hosting a student and new graduate event in Victoria. So if you're a Victorian-based student sonographer or recent graduate, you're very welcome to attend. We've still got limited places available, and the event is held in Notting Hill, which is just off Ferntree Gully Road near Monash University. Also coming up on the 28th of March, we're supporting ASMERD. ASMERD are starting to do some ultrasound programs as well. And we've got the Super Sonography Saturday program with Andrew Brandt. In 2026, we're also running 3 anatomy days. These are days where we have hands-on anatomical laboratory sessions in the morning, and then with a focused didactic scanning session in the afternoon. Our Perth Anatomy Day, which is on upper limb, is just sold out, but people in Perth are still welcome to join the wait list. And our next Anatomy Day will be on, after that, will be on the 5th of September in Sydney University. And it'll be on lower limb, and tickets for that will be on sale on the 1st of May 2026, so watch out for that. So turning to tonight's presentation, Professor Mary Rickard, as I mentioned, is a Sydney-based radiologist. She's an adjunct professor at the University of Sydney. She's the medical director of Sydney Breast Clinic, and also too, she's the chief medical officer and co-founder of DetectedX, an image-based online learning platform. And we're going to have Q&A at the end of Mary's presentation, so you can submit questions, but it will be after the presentation that we'll do Q&A. And online now, we have Professor Rickard. How are you?
Good. Thank you very much for the invitation. Hopefully this will be an enjoyable evening for all of us involved, and I'm really looking forward to this presentation.
Okay.
I'm good. I'm just going to swap over now to sharing my screen, if that's okay. And hopefully you can all see the screen now. And as you can see, the title of the presentation is Breast Imaging and Mammographic Breast Density. I think it's a really interesting topic and I hope you enjoy it. So for this particular presentation, this is the outline of what we'll talk about. We'll talk about mammography and other breast imaging options, breast density, what it is and why it matters, and reporting breast density, what to do about it, how to assess risk, and the supplementary screening options that are available now, and what's the future direction for all of this. So certainly the imaging options have been stable for a while. We have a range of imaging tests available to us, mammography, which is typically full field digital mammography, or 2D as we call it. And then there's digital breast tomosynthesis, sometimes called 3D. There's ultrasound, which can be handheld, and while not widely used in Australia, there's automated whole breast ultrasound, or ABUS. Contrast-enhanced mammography and contrast-enhanced magnetic resonance imaging, or MRI, be it abbreviated or full, are also available. So all of these imaging modalities can be used for either screening or diagnostic work. So screening, of course, is for asymptomatic women, and diagnostic is for symptomatic patients. And mammography is, generally speaking, our typical primary tool. Unless the patient happens to be young or pregnant, we may go to ultrasound first, but it's our typical primary tool. And I want to talk a fair bit about that tonight. We always need to put our imaging in a clinical context so that we correlate both the clinical imaging and biopsy findings, because all of these components together will give us the best answer or the best diagnosis for the patient. So mammography is the primary tool, as I mentioned, but what limits it is mammographic breast density. And this is a ratio of the fibroglandular tissue, which is the white tissue on a mammogram, to the black components, or the fatty tissue. It changes with age and physiological states and medical interventions, and we'll go over that in a second. There is also a wide distribution of densities across any age group. So we can see that illustrated here in this bar chart. If we look here, let's look at the purple. We can see that the extremely dense is quite common in young women, and as women age, it becomes lower in percentage, but it's also still, relatively speaking, common in older people. So it doesn't disappear, it just becomes less common. So your density is largely genetically determined, and it's associated with a couple of significant risks, which I'll mention in a moment. And we classify it, generally speaking, like this, based on the fact that there is an increasing density pattern here, A and B, which are these low density patterns, and C and D, which are the high density patterns. So the determinants of mammographic density are largely genetic, but there are modifying factors, right? The modifying factors that might change your density are, for example, it will go down with age, parity, number of births that you've had, increasing weight, menopausal status, and treatment with tamoxifen or radiotherapy. Breast density will go up with a greater birth weight or a greater height, family history of breast cancer, lactation, combined hormone replacement therapy. But as I mentioned, the genetics really determine your underlying density. And there was a twin study that showed that identical twins had very similar breast densities, and non-identical twins who share half their genes had breast densities were about half as similar. So we believe that heritability accounts for about 2/3 of breast density. We also know that there are common breast cancer susceptibility genes that actually have been shown to be associated with higher mammographic density. So the anatomical components that lead to density are these, as demonstrated by Tabar. You can see that the first are nodular densities, or the little TDLUs or glandular structures in the breast, and they appear as little round dots. The next are linear densities, which typically are ducts, vessels, fibrous strands. Then we get the homogeneous sort of white tissue in the background. This is the structureless fibrous tissue. And then we get the black background, which is the radiolucent adipose tissue. And the mammographic density, as we know, reflects the proportion of these, the proportion of the epithelial and fibrous connective tissue to the fat. But both of these white densities, the fibrous tissue and the nodular density, which is coming from the glandular tissue, are important because the glandular tissue is where the cancers arise from, but the stroma or fibrous tissue facilitates the progression of cancer. And so both of these are important factors when we're estimating density. And we can estimate density based on the pattern of the breast tissue or the amount of it present. And in the early days, back in the 1970s, actually, Wolf had a very effective pattern, but which divided the breast up into low-risk patterns and high-risk patterns. And Tabar in the 80s had a similar categorization. He had 1, 2, 3 as low risk, 4 and 5 as high risk. And I've just illustrated here the 4 and 5 patterns. In this pattern here, which is pattern 4, the densities are rather nodular or round. They're made up largely of these nodular densities, whereas in this pattern where it looks rather smooth and whiter, this is because there's a lot of homogeneous background fibrous tissue. So you can see that both of those patterns are quite different. On the other hand, they're both important. But currently, we're actually not using a pattern recognition much. We actually use the ACR BI-RADS descriptors, and they go from predominantly fatty, scattered tissue, heterogeneously dense, extremely dense. It's a relatively easy categorization to use, but it's not quite as meaningful as the qualitative patterns that we have seen on the previous slide. We also know that we typically can do it either by radiologist visual interpretation or by some automated process, but neither of these are particularly, I'll come back to that, particularly meaningful. And there's a move towards now radiomics, where we get AI assessment, which incorporates both pattern and volume. Firstly, I want to point out that visual assessment by radiologists is very unreliable. And in summary, in this article, they said that the likelihood of a woman being told that she has dense breasts varies substantially according to which radiologist interprets her mammogram. So we've moved away as much as possible from visual interpretation to something that's automated like this. And visual assessment is a bit subjective, because when you look at the 2D mammogram, you may see a sort of rounded area of density here, but you don't know how thick it is. And when you look at it here, you can see that there are 2 layers of fat in this particular diagram, of tissue in this particular diagram. But, you may not actually visually interpret these as being different because one overlies the other. So when we go to the automated system, it actually does a percentage volume. It measures the data pixel by pixel, and it actually estimates how much density there is by comparing it to a 100% fatty pixel, and it gives us a percentage volume. So we can see that there's a volume of the tissue present, a volume of the breast, and then we get a ratio of these. And then it categorizes it into the BI-RADS of A, B, C, D. Of course, we need a reliable test. We can't use visual if we're actually going to look and consider supplemental screening strategies. So what are the risks? Why would we consider supplemental screening? Well, basically there are 2 risks attached to breast density, but this meta-analysis back in 2006, 20 years ago, showed that of the studies that were available, almost all of them showed that increasing density was associated with an increasing cancer risk. And the risk, if you compare a very dense breast with a very low fatty breast, you get about a 4.6 times a risk of having breast cancer. A similar study at the same time showed that if you looked at the odds ratio for detecting breast cancer or having breast cancer, we could see, even if you adjust for all the risk factors that we know of, increasing density led to increasing risk. Overall, there was about a 4.7 times increased risk, but there was a big difference between these 2 risks. The risk of being screen detected and the risk of having an interval cancer detected between screens. So there were 3.5 times the increased risk, or the odds ratio is 3.5 times, to have a screen detected cancer if you have dense breasts or extremely dense breasts. And that's because there are, of course, more cancers in that group of women. But if we come to this factor, the risk of detecting interval cancers, it was nearly 18 times in the first 12 months after what was reported to be a normal mammogram. And that's because we can't always see the cancer in this dense mammogram. Even in the second 12 months post a normal screening mammogram result, there was a times risk of having an interval cancer. So this is just to illustrate that. We've got our white dot, the cancer. We can see that it's less easy to see the denser the breast tissue gets. Here we have a little cancer that's easy to see because it's just in the middle of a fatty breast. In this particular breast, we can't see the cancer, and we never will be able to because it's buried in this dense glandular tissue. In this case, we can actually see the little cancer. It's actually this density up here. And the reason we find it is that it's in the wrong place. But were it to be in the middle of this glandular tissue here, we would no longer find it. So clearly there's a problem of masking. So this led to a lot of lobbying from the public. And in the United States, in 2023, the FDA published a rule that stated that all mammogram reports had to include breast density. Was the patient's breast dense or not dense? And in similar, a position statement from the Breast Screen Australia was developed in November 24, when they said that women should be informed of their breast density and they should be advised to go to their GPs and discuss what should be done next. So the states have intermittently or gradually taken this up. So New South Wales Breast Screen took it up in April 25. So they're all slowly adopting this policy across Australia. And this is just an example of an information sheet that's given by Breast Screen to doctors, to GPs, giving them some information about what breast density means and what they might be able to do. It's quite complicated. I'm sure you can't read it, but basically what it says is, why do I need to know about this? It discusses the idea that there is breast cancer risk. It also says what you might be able to do to estimate risk other than density. It talks then about alternate modalities such as DBT, ultrasound, SEM, MRI. And so it's basically an outline on how to progress once you find out that you have a dense breast. I want to just comment on this, which is a general statement, but it also applies particularly to breast cancer screening. And that is the evolution of personalised imaging and care. So back in the 70s, the approach to imaging, for example, would have been that every doctor knew best what to do, and that's a rather chaotic sort of approach to medicine. But back when breast screen was started in the 1990s, we took a one-size-fits-all approach. That is, it was standardised, all women got the same care. And it was basically we had access to large data and we wanted to make the services accountable, so we standardised lots of things within the program. But now we've had this move towards individualised care, and it's common across wide areas of medicine. The idea is that we have lots of data available now, and we can drill down into that data, and we can do data analytics and also involve our patients in engaged care. So personalised screening means that we have to be able to assess personalised or individual risk. And we know one factor of that risk is mammographic breast density. So here's the setting of mammographic breast density. It fits up the top with what we know are really high risks, gene mutations and strong family history. High breast density fits up in that level of risk. If we go down, we can see there are people who previously had cancer at high risk, people who had a risk biopsy, a risk lesion on a biopsy. We can go down then to other things like hormonal history, ethnicity, lifestyle, including exercise, alcohol and weight. And these, while they are modifiable, you can do something about them, they're relatively low risk components compared to density. So the question is, how do we actually estimate risk? What do we have in the way of risk tools? And there are a lot of risk tools available. We've got things like Tyrer-Cuzick, Gale, iPrevent, lots of them on the market, lots available. But I just want to illustrate here what happens if you take the Tyrer-Cuzick version 8 and you input a whole lot of standard values, so all the risks being the same except for mammographic density for two 50-year-old women. And you can see in this patient who has low mammographic density, her risk 5 years, about the third that of the population risk at large. If you input the data so that it's high risk, her 5-year risk is about, well, more than 2 times. So this is a way of estimating how we might approach risk-based screening. But what about this? Can just a mammogram replace these risk assessment tools? Well, the current tools are actually quite time-consuming and they're not very accurate. We do have a study, and a number of studies actually, but this one back in 2023, which looked at risk based on using a couple of AI radiomic tools, one for lesion detection and one for tissue texture. And what they did was they analysed the tissue texture with AI, they looked at the lesion detection scores with AI, they inputted the mammogram, and they created a combined risk score. At 90% specificity, they were able to predict about 40% of the future breast cancers that were likely to develop. The area under the curve, which is a measure of the accuracy of the test, was about 0.73. This is the curve, typical AUC curve here. And this is better than Tyrocusic or any of the other risk tools that we currently use. And it also avoids all the problems of data collection and processing, the time it takes to collect all the information to input, and the inconvenience associated with these tools. We actually have the BRACES risk model tool, which has actually been developed in Breast Screen Victoria by Helen Fraser and colleagues. And basically what they have shown is that they actually can achieve an area under the curve that's about 0.73, which is similar to the curve or the findings that they were able to get in the Lawrenson study. So we can predict risk better than we can with using our risk prediction tools just by looking at a mammogram. And that's led to the first FDA-approved software on the market called Clarity. This Clarity is a platform or an AI-authorised platform that predicts a woman's 5-year future risk of developing breast cancer using only her existing mammogram. And this has been started to be used in the United States earlier this year. So let's come back to how we might improve our outcomes with screening, given that we know that mammographic density is a problem. How will we address it? Well, we could address it by looking at the frequency of the screening that we do. We could look at using AI tools to improve our screening outcomes, and we could look at the modalities that we use to improve screening. So if we look at the frequency and we changed our biennial screening program in Australia back to an annual, we would actually address the cancers, the interval cancers that occur in the second year or later, but we wouldn't actually affect those that occur in the first year. So it has a value, but not a very great one. So the other option is we can use AI to make sure that we don't miss any lesions that are actually present on the mammogram, but that the radiologist hasn't perceived. And this is a very useful tool that's currently in increasing use. Then we have the option of looking at different modalities. We could look at DBT, ultrasound, contrast mammography, and magnetic resonance imaging. So the MASSI study is just a nice example of how AI can improve outcomes. In this particular study, in the screening program, they randomized their patients following and used the risk tool, the AI, to triage their intervention group. So they had a control group of women that just had the standard process. That is, they were double read by 2 radiologists without any AI. Then they had an intervention group where they used the AI to triage with a higher risk group or into a low risk group. And the high risk group, they actually had 2 radiologists look at the AI and read the mammograms. And in the low risk group, they just had a single radiologist read. And what they were able to show by triaging in this way was that they actually detected 22% more cancers than they had in the control group with the AI. They didn't affect their false positive. In other words, they didn't call more women back for assessment, but reduced their workload by 44% by cutting back to single reading in this group. So there's a benefit there for workload or addressing the workload issues and also addressing the cancer detection issues. And this is just an example of a case where the patient has got AI markers on the mammogram. We can see that these areas are not very obvious when you come over to the real mammogram itself. You know, I think it would be hard to actually perceive any abnormality in these 2 areas. But in fact, only one of these areas is actually a cancer. And likewise, here we have 2 areas identified on the by the AI, but one of them, this one, is the cancer, and this one is the cancer. So we can see that after we've gone and examined this particular case with ultrasound, we've found the cancer, and why it wasn't terribly obvious on the mammogram is that it's not a very spiculated lesion. It doesn't have a lot of disturbance of the adjacent architecture. It's just a soft tissue lesion, and it's sitting here, and we can see where it is when we've gone back later and actually done the marker clip. So here we can see the lesions here, and here's the marker clip that correlates. We can see that the lesion's here, and here's the marker clip that correlates. So it actually shows you how it helps the radiologist to interpret that mammogram, but it does give you lots of false positive marks that turn out not to be cancer. The other options, we go now to talk about the imaging, which is possibly something you're more interested to hear about. So what about digital breast tomosynthesis? Well, we achieve that by moving the X-ray tube across a series of angles over the breast, and we take multiple low-dose projection images, and then these are reconstructed to give us a series of millimetre slices through the breast. And this is just to illustrate the theory of it. You've got a purple cancer, you've got blue fibroglandular tissue around. When you take your mammogram, the cancer is hidden by the overlying blue fibroglandular tissue. But if you go through the breast slice by slice, you are at one stage able to uncover the cancer and make it more obvious. And we can see that in this particular illustration here, there is a bit of a bump on the contour here, but it doesn't look malignant. But when we look at it here, we can see that there are lots of streaky spiculations attached to this mass, and there's clearly a malignancy there. So digital breast tomosynthesis was first introduced into the trial setting anyhow, over a decade ago now, back in 2013. And across all the studies, it showed that, for example, the Oslo and the Storm studies, that you could increase your cancer detection rate significantly, and you could also decrease your false positives significantly. And this was true across all age groups and all densities. So not just dense breasts, in fact, it's got a limitation that it's still affected by mammographic breast density. If you don't have any fat around a lesion, a soft tissue lesion in the breast, it'll still be difficult to see regardless of the fact that you may have tomosynthesis. But all breast densities, all age groups benefited from an increasing cancer detection rate. So why isn't it in screening programs widely used already? And the main problem has been that, in fact, none of the studies so far have been able to show significant differences in interval cancer rates or advanced cancer rates. And so it raises a question of whether the cancers that are being found, in addition to the underlying mammography detected cancers, are actually meaningful, or are they due to what we call overdiagnosis, where you find cancers that are not clinically relevant? Well, let's move on to ultrasound. So we have the option of handheld ultrasound, and as you know, it's the most commonly used complementary tool with mammography, and it's widely used. And it would be, I think, mammography and ultrasound considered the standard of care for dense breasts currently in clinical practice in Australia. We use it with mammography, particularly in dense breasts or in younger women or pregnant women because of the radiation issues. It's often used in diagnostic settings because we can target it quite readily to the mammographic or the clinical area of interest. But it's also used in screening just because it increases our sensitivity in screening programs. Unfortunately, it actually decreases our specificity. That is, we find lots of things on ultrasound that turn out not to be meaningful. It has a greater sensitivity than mammography alone, and greater again if it's combined with mammography plus or minus DBT. But it has a high false positive rate and it's operator dependent. And if we look back at this study from 15 years ago, the EVA study, which looked at family history screening, you can see that this is the detection rate for mammography alone. This is the detection rate for ultrasound alone. It's higher than mammography. And when you combine the two together, you get a significant improvement in cancer detection rate. What about ABIS? Well, as I mentioned, we don't use it very much, but there is quite a lot of literature on ABIS from Europe and the East. And basically it shows no significant difference in cancer yields between handheld and ABIS studies. What happens here is you get a large or a wide probe which moves down the breast and acquires a series of images. Typically 300 are collected per breast. And these images are actually reconstructed into such a way that we can get multiplanar images, such as this coronal image that we can see here. The nipple has been marked here by a marker, and then we can see adjacent or nearby there's actually this stellate lesion. It's black, but it's also got these spicules coming out, which we can see a bit like we would see on a normal mammogram. And that's better seen than on the typical scans that we do. It's much less operator dependent. It doesn't take very much time to do a full breast ultrasound. Bilateral breast ultrasound is probably about 15 minutes, but it does take a longer interpretation time and really requires AI to help for lesion detection because of the problem of so many images for the radiologist to review. But I want to touch now on the next really big topic, which is contrast imaging. So contrast or vascular imaging includes both contrast enhanced mammography and MRI. And the reason that contrast imaging is so valuable is that it's not limited by mammographic breast density. It detects neovascularity from tumour growth, new vessels that are growing to supply a tumour, and leaky vessels that are related to that. When you do a SEM, you get a morphology. You can actually see a mass lesion on the mammogram or a spiculated or rounded one, whatever it might be, and you get that imaging that you get from a normal mammogram along with the vascular information. On MRI, similarly, you get morphology from the MR imaging, but you don't actually see the calcifications, which if you want to see the calcifications would require mammography. So this is just an illustration of what we're actually looking at here. This is our normal mammography DBT situation at the moment. We're looking for the mass lesion. And it happens to have neovascularity because that's the situation. Every tumour grows new vessels. But what we want to do is move it back in time when the mass is not very obvious, in fact, may not be evident on the mammogram, but the neovascularity is still present. And at that stage, we detect contrast changes without actually having to see the mass itself. So just to illustrate back to this EVA study, we can see we saw before mammography had a detection rate, ultrasound a detection rate increased by combining the two. If we compare it with MRI, which is available, as I mentioned, this is a study from 15 years ago, we got 3 times the cancer detection rate that we got from mammography alone. If we actually add ultrasound to the MRI, we didn't actually add any cancer detection. If we add mammography to the MRI, we do get a slight increase, very slight increase in cancer detection, which is based on the fact that we can find the calcifications and the DCIS, which may not enhance. If we add mammography and ultrasound, the ultrasound addition doesn't add anything to having added the mammography. So why is it that MRI is so good? Well, you can see here that, the tumours tend to light up very obviously. It's clearly what is considered to be our most sensitive breast imaging tool for cancer at the moment. And it's recommended for extremely dense breasts, for example, by USOBI, the European Society of Breast Imaging. And it's recommended to be every 2 to 4 years, not as frequently as mammography screening because of the fact that it finds the cancers so early. But there are limitations attached to MRI. One, it may miss calcifications. There's a problem around patient acceptance and tolerance of it. Many people won't tolerate MRI. There's a cost. There's a time problem. There are problems with ferromagnetic implants. There are patients' problems such as patient size and inability to lie prone. With contrast-enhanced mammography, we take 2 sets of images and we subtract them to get a third or contrast mammogram. So we get what we call a normal low energy image, which is this appearance here. And after subtraction, we get what we call a recombined image, which is this image here. And these recombined images are unaffected by mammographic density. So we can see in this cancer case, there's a cancer evident on the 2D image, and it's lighting up on the recombined image. We can't see any abnormality in the left breast because the tissue is too dense, but there is a small cancer which is lit up on the contrast images, but not visible on the 2D because of the density. And this is just to illustrate that the same lesions were shown on MRI. So we get good combination of both morphology on the low energy images and the contrast abnormalities on the recombined images. And SEM has been shown in the literature to be a viable alternative to MRI. It's quicker, less expensive, more widely available. We don't have the problems that we have with ferromagnetic implants, claustrophobia, weight, etc. And it basically has the same sensitivity and specificity as MRI. It does have one significant problem, which is the issue of contrast anaphylaxis, which when it's severe can cause death in less than 1 in 100,000 patients. And this is just an illustration of this. There is a little density in this mammogram, and in fact it has been identified by the AI on the CC view only. Hasn't been given a very high score, but it has identified. It's this little area on the mammogram, which when we see the contrast images just shines out. We can see quite clearly that there's a hard to see abnormality on the MLO, but straight away we can see it on the AI, on the SEM images. There are no AI tools for SEM at the moment, but there are some under development. So I just want to tell you about a couple of recent studies that illustrate the difference in the importance of different comparative supplemental breast imaging techniques. This was published last year. And basically in the UK, they took a group of normal women with normal screening mammogram results, and they had also BI-RADS CD density, and they offered them supplemental imaging with ABUS, SEM, or abbreviated MRI. And they randomized the patients by site, that is, different screening sites offered one of these different options for supplemental screening. And their study, they said, was based on the evidence that they have that MRI is superior to mammogram plus DBT plus ultrasound, that abbreviated MRI is equivalent to a full MRI, that SEM is equivalent to MRI, that ultrasound increases cancer detection over mammography, and that ABUS is equivalent to handheld ultrasound. Anyhow, these are their results. So the results of the BRAID study are quite impressive. They found additional cancers, but the additional cancer detection rate over and above what was found with the initial mammogram was 4.2 per thousand for the ABUS group, but it was 17 and 19 for the MRI and SEM groups respectively. The number of invasive cancers that there were for the total number of cancers that were found were 9 out of 9 were invasive and ABUS. So in other words, it didn't find DCIS, it found invasive cancer. For MRI, there were 32 of 37 that were invasive and 32 of 39 for SEM, because it found a few additional ones that were only evident due to the calcifications. The average tumour size was smaller for the contrast studies, 10 or 11 millimetres compared to ultrasound, which is 22 millimetres, but ultrasound had a lower recall rate than the contrast imaging studies. There are obviously lots of issues to be discussed about cost benefit, etc., but the results are very impressive. So there was also another article last year that looked at supplemental imaging, a systematic review of different modalities from the literature. They base this on the fact, their premise, that standard mammography alone is insufficient for detecting breast cancer in individuals who have high breast density breasts, that there were a range of adjunctive imaging options, and they wanted to consider the cancer detection rate, interval cancer rates, recall rates, positive predictive value, etc., for these different modalities that are available. What they were able to show was the additional cancer rates in the literature per thousand. With DBT was 1 or 2 cancers extra per thousand, with ultrasound 2 to 3 extra cancers per thousand, with MRI 17 plus, and with SEM 19, but this is based on a single study, the BRAID study that I just showed you. So we have this additional cancer detection rate. The other findings from the literature would suggest that recall rates are actually reduced if you actually include DBT, because you sort out some of the densities that are on the mammogram are just due to overlying tissues. But in ultrasound, unfortunately, they're increased because of the fact that we find little dipsels that we're not sure what they mean. If we look at biopsy rates, DBT didn't have any significant impact on biopsy rates, but ultrasound, in fact, increased biopsy rates overall. If we look at interval cancer rates, the only modality we have that's so far been proven to reduce interval cancer rates is actually MRI. But we reviews for breasts. So just in summary, for what we've talked about, we know that 2D mammography limit is limited by breast density, and that's a significant limitation, and it's important that women know their breast density and are able to act accordingly to address it if they wish to. We can improve cancer detection by a range of different activities. We can add supplementary screening modalities, which have a range of benefits, not all equal. We can add radiomics, AI, particularly for lesion detection and for assessing risk overall. And we can decrease the screening interval by having annual rather than biennial screening. There are other things that are also in the mix at the moment, and there's a lot of interest in biomics or liquid biopsy, looking for circulating tumour cells or circulating tumour DNA, or lipidomics, which looks at various lipid levels in the blood for the detection of breast cancer or for breast cancer recurrence. And in fact, the FDA has already approved several of these liquid biopsy tests in looking for, in the blood, for markers of metastatic breast cancer. So I hope you've enjoyed this presentation, and I'm happy now to take any questions that you might have. Thank you very much. And I'll stop sharing my screen at this stage. Thank you.
Thank you, Professor Rickard, for that presentation and getting us across all the imaging modalities available for breast lesion detection. Just to catch up with people who may have joined us after the start of the presentation, if you've got a question, please pop it into the question box and we can answer it. We've actually got plenty of time for questions, which is terrific. You mentioned there, Professor Rickard, about the AI. Clearly, AI is going to feature more and more in the future. Is there any trends or any insights that you can give us about what's going to be around the corner?
Well, I think AI in breast work is being used in two main areas at the moment, both of which I mentioned. The first one being lesion detection, right? So this is, I think, a really important one, not just for screening, but for lesion detection in symptomatic women as well, because it can be hard sometimes to identify the lesions, or let's say you can also be distracted or whatever. So it's a really good reminder of what to look at. Like it's a good indicator of where there might be a problem. It does have the problem, however, itself of being giving you a lot of marks, a lot of false positives. And that means you look at a lot of things and have to dismiss them. The second big area that AI is being used in breast is actually this whole risk assessment area, right? And clearly radiomics of the breast, that is, it really reflects what was happening way back in Wolf and Tabar's day, right? In the 70s and 80s, when they were using a breast pattern to predict the likelihood of breast cancer risk, right? We moved away from that a bit to looking at just density on its own, right, over the years. But in fact, it's not just the density that matters. It's more about the way that density is distributed in your breast that matters. And so the radiomics is able to do that. It's able to do a pattern analysis. And given that with breast cancer screening, we have lots of data where we can feed the AI tool the current mammogram at the time of diagnosis, the one a year ago, the one 2 years ago, 3 years ago, 4 years ago, it can then see what it was 4 or 5 years ago that might have led to an increased risk here. Like, it can identify that. So it's a very good tool for looking at short-term risk prediction, which then leads you to a way of managing patients in the short term. And, interestingly enough, you might never have thought of it this way, but, your breast pattern is more or less like your fingerprint. It's particular to any one woman. It's a particular pattern. So it is of individualized risk. And when we use those other tools, like whatever they may be, Tyrocusic or whatever, any of those risk tools that we currently use, they're actually more accurate at a global level. If you've got 100 women, then, it can tell you the percentage that are likely to go into a problem, but it's not individualized. There's no individualization in that risk tool.
Okay. We've got a question, and it's from Alan. Do you think Medicare rebates for MRI should cover those with dense breasts? As in Australia, it would be very costly for patients to access this modality.
Well, I have to say I have a bias towards SEM, right? I think that, while that study that the last study that I referred to in the presentation talked about the economics of screening for dense breasts, it's a really big issue, and they didn't come to any conclusions, because the problem is it varies a lot from country to country, and there are a lot of factors influencing the economics of it, right? So we know that breast cancer screening with mammography alone is quite economical or advantageous. It's cost effective, but we know that it doesn't help a percentage of the women who are attending the breast screen program. And the government so far has been reluctant to actually move towards what is the best way of dealing with dense breasts. And that's because there's really a lot of controversy around the economics of it. MRI, as I mentioned, is quite expensive. Were we to use it for all dense breasts, it may prove to be cost ineffective and also very difficult to access, right? Because, as you know, there's a lot of other things that MRI is being used for in this country. So access to the equipment is quite reduced. So I don't think that it's a really great idea that we actually broaden the Medicare rebates for MRI breast necessarily, because I think that the evidence suggests that SEM, contrast enhanced mammography, is equivalent to MRI in terms of cancer detection in the breast. It's much more widely available. It's much less costly. It's quite easy to do, and quick and easy, relatively accessible. So I feel that there should be more emphasis on training people up to accurately interpret SEM and to offer SEM more widely.
Okay, thanks for that question, Alan. Next question is from Susanna. Do you know of ABIS being used in clinical practice very often in Australia? Because you talked about handheld and ABIS. What was the data presented from Australian studies, uses, or were they all overseas?
All overseas. So there is no data from Australia as such with ABIS. We do have an ABIS machine at Sydney Breast Clinic, and there has been one in use in South Australia for, I think, a decade now. ABIS has been around a long time. It's not like it's novel, but when it first was introduced into Australia about a decade or so ago, just at a sort of trial level, most of us felt it didn't really match the quality of handheld ultrasound. And handheld ultrasound can be really of wonderful quality, but of course it requires a skilled operator. And that is a big limitation with ultrasound. The workforce around ultrasound is limited, and it requires time for training and to gain expertise. So there is a growing demand for ABIS, and particularly in the States, since the FDA approved or mandated the reporting of breast density, there's been an increase in the sales of ABIS equipment in the US, and a lot more interest. And I think, to be honest, that will be a growing area. The two growing areas that I see, of course, are AI in general, ABIS, and SEM.
Okay. And of course, if you want a good handheld system, Canon's got them all.
Yeah, you're right there.
Terrific. Got a question from Jenny, and Jenny, I hope I get all this right, that you're concerned about that focused ultrasound in experienced hands has been underestimated in Australia, and that we're just wanting to get a comment on the reduced specificity of MRI scans. Jenny was saying that in her practice requires ultrasound correlation because of the reduced specificity.
Yeah, so I guess that really touches on the role. Well, firstly, two things, doesn't it? On the quality of the ultrasound, and I'm 100% behind the idea that we want quality ultrasound, because quality ultrasound is a wonderful tool, right? But it does require expertise, and it does require training to gain that expertise. So that's the first side of that question. But the second side is, when do we use it really in association with MRI or SEM? So there is a role. And so, for example, at the clinic, we would normally, and this is, I think, international practice, that you, following SEM, if you have a normal study, there's no need to go on to ultrasound because it doesn't add anything. I think I pointed that out in several times in the lecture. But if you have any question, for example, you have an area on the contrast mammogram or the 2D mammogram, the underlying mammogram, that looks atypical, because contrast can have false negatives, you have to examine both sets of images. And if there is any query on either of the images, then you need ultrasound to sort that problem out. If the patient is actually symptomatic, regardless of whether the contrast mammogram is normal or not, or the MRI is normal or not, you would normally do targeted ultrasound. In our own clinical practice, the introduction of SEM had a significant impact on the use of ultrasound, but we use a lot more targeted ultrasound, but it remains an essential tool to be coupled with contrast mammography or MRI.
Okay, thanks for that question, Jenny. Next one's from Helen. Women are visiting their GP after a density report through breast screen. GPs are then referring women with high density for dense breast tomogram. Is this acceptable less than 12 months after initial screen from a radiation point of view?
Well, I guess I would say, firstly, I don't think that the radiation dose from mammography is a concern as such. However, I don't think it's good practice, what we're saying here. Repeating unnecessary repetition or repeated exposure to radiation, that's not good clinical practice. And it is a pity that we don't have a more standardized approach as to how to manage density from the breast screen services. So at the moment, it's very random, isn't it? The patient basically gets a letter, the GP gets a letter, it says that the patient has high density, and then it's up to the patient and the GP to determine what to do next. It's a very difficult thing, I think, for a GP, because they're actually not necessarily skilled in this area. And yeah, it's very difficult for a patient because they're guided by their doctors often. So I think this is all a difficult topic, very difficult for both the patient and the GP. It does lead to unnecessary imaging. It does lead to inappropriate imaging. Yeah, so I think over time, I'm sure that breast screen will actually come with an approach to try and do a more systematized, but at the moment it wasn't their choice.
Okay, thanks for your question there, Helen. This next one is from Susanna. What is your experience with percentages of unhelpful background parenchymal enhancement in contrast enhanced mammography? Do you know of any accessible information on whether it's better to have more or less contrast in CEM, and a good calculation of how much contrast per patient? Is it based on the weight of the patient or size or density of the breast? Thanks again.
Okay, so, there are guidelines on how to use the contrast agent, but a lot of it's just been really taken from experience in the past with using contrast for other studies, like CT, for example. A bit experimental. There's not a lot of science behind exactly how much contrast agent you use, etc. However, most of us would use contrast agent based on the patient's weight. That's the typical approach to the use of contrast. And I guess for us, usually 100 mils would be a max dose, approximately. So the dosage is, generally speaking, related to weight. It isn't related to what the breast tissue looks like, because the way the contrast circulates or appears on the contrast enhanced mammogram is unrelated to the breast density. You do get background parenchymal enhancement that's very variable. You can have a D-density breast, and you have almost minimal BPE. You can have a very fatty-looking breast, pretty easy sort of breast, and you'll get a lot of contrast enhancement. So it's not really related, but background parenchymal enhancement is a problem on contrast enhanced mammography. And if you have a lot of BPE, a lot of background parenchymal enhancement, it can mask a focus of enhancement from an abnormal area in the breast. So it is a reason for why you might miss a cancer or a significant finding on SEM, because the background parenchymal enhancement is high. So it can be a reason for false negatives.
Okay, thanks for that question, Susanna. We've got one from Donna. Some women may have an area of dense tissue in the breast within which cancer may be masked, but this is unlikely to be flagged as a dense breast, by example, Volpara. What are your thoughts on this aspect of breast density in terms of supplemental screening?
Well, I think that's the problem that we were referring to, or I was referring to earlier. That is, currently we just have this idea that we'll measure an ABCD, largely fatty, extremely dense, and something in between. And it's not very meaningful. And that is part of the problem we have at the moment, and if you use a tool that gives you a percentage density, it averages out the density across the breast. It doesn't tell you that the upper outer quadrant is dense, but the rest of the breast is fatty, or that this is a uniformly mildly dense breast. So that's the problem with the type of tool that we use now, where we have actually a percentage density. Whereas the AI radiomics will give you a much better estimate, and of course that's not clinically available at the moment, but the AI radiomics, which is coming into clinical practice, will give you a much better indication of the likelihood of risk and masking.
Okay, I've gone over to the Q&A questions. Do you think adding DBT for screening, just one view, could reduce the number of callbacks for assessment?
Yes, the reason, there are a couple of reasons that DBT hasn't been introduced. As I mentioned, the main one has been that the big studies that have done DBT in screening haven't actually shown a reduced interval cancer rate, right? Those cancers that occur after a normal screen in the interval between screens. But there are quite a few studies, and there was one study, particular Swedish study, that actually looked at single view DBT and was able to show that it significantly impacted on cancer detection rates, and it also didn't significantly affect the number of women that were called back. I think that study, if I'm correct, did decrease recalls just slightly. The dilemma with whether these increased cancers that we find is that, how do you prove that the cancers that you find are meaningful? And I know that sounds a little bit strange, but basically the idea of finding cancers that aren't ever going to be clinically relevant in a woman's lifetime is quite real. We just don't know the magnitude of the problem. And the other problem we don't know is that, is it when we actually find a cancer, we don't have a means at the moment of saying this cancer, which is small now, would have become big in a reasonably short time and would have been meaningful for that woman, could have metastasized and caused her death. So the whole classification of overdiagnosis and over-treatment is quite a complex one. However, the question was really about, do I think that TOMO would help? I do think TOMO would help, because TOMO is actually widely used in private practice. And the main reason I think it's widely used is it does give you a level of reassurance, right? The densities that you see on the mammogram are nothing relevant. They're not important. And that's a really nice, reassuring finding when you can actually TOMO through an area and see that it's actually normal. So I think it would help. The other thing that I should mention, I suppose, is the other reason why it was not rushed in breast screening is that there's a time to interpret tomograms. There's a learning curve. Initially, when people first start to read tomography, it probably takes twice as long as reading a standard mammogram, and although that can decrease over time. And that means additional costs. And if you're looking at cost effectiveness of a national screening program, that impacts on that. It makes it a higher cost screening program. Obviously, that's not as much of a factor when you come to private practice.
Okay, I've got a question here. I'm trying to pick up the strands of what people may have replied for other things, but I'm going to go to one that Jenny's put about. So Breast Screen Australian government will refer those with a category 3 and 4 breast density to then do other imaging that is not likely Medicare funded, I suppose. And Jenny's question, is that fair? Because clearly a cancer in a 50-year-old is likely meaningful until determined. So just any comments on that?
Well, I think this is the big issue, isn't it? This is the big concern. So the government wants to try and offer a screening program that's equitable, that's available for all women across Australia. And they have offered up till now mammography-only screening. And the more information that we've had on density, the more we've realised that it significantly impacts a certain group of women. And that certain group of women who are going to the government screening program to have a mammogram every 2 years and nothing more are missing out on any benefit. So is it right to then say, well, okay, go and make your own choices? Because then it becomes a difficult situation for women who are not particularly well off. There is an inequity there, isn't there? It's no longer equitable in terms of access, because it's very uncommon in screening program in private practice to actually get Medicare only imaging done. So people are going to have to pay out of their own pocket for this, and it's going to be random based on what the advice has been from the GP, as well as the concerns of the woman herself. So I think there's lots of inequity in the current arrangement.
Okay, I think we've come to the, I think I've covered all the questions. Now we've actually got another one, and it's from Dan, and it says, good morning from Norway. AI is integrated more and more in ultrasound system. What is your experience in the lesion detection of AI if you compare an inexperienced user or an experienced user? Does the AI software cover the experience gap between the operators?
Well, I think you do have to learn to use AI. Right? It's not, use AI well, let's put it that way. As you know, you can set a threshold with AI as to how many marks you want the AI to be giving you, at what percentage sensitivity do you want it to have, etc. So within a screening program, that's probably a stable thing. It's quite straightforward, I think, in screening, because we know what the recall rate might be for the country. You can set your AI accordingly. In private practice, if you're doing a mix of screening and diagnosis, it can be quite difficult to determine. But let's say you've determined that AI is always inevitably going to give more marks than there are cancers. So you always have a false positive rate. And the difficulty, I think, for younger or less experienced radiologists is to differentiate those false positives from the true positives. And that's a difficulty in the beginning, that you have to learn to go, to be confident in yourself. If you don't see anything immediately in that area, then there probably isn't anything in that area. Do you have to go and do extra spot views and tomos and slices and ultrasound and whatever? Well, this is a matter of experience, isn't it? The less experience, the more likely you are to be doing extra tests for areas that have been identified on the AI but are not actually a cause of any problem. So, yeah, I think you do have to learn to interact with the AI. But as you saw from the Massai study, it can have a really great beneficial effect if you are an experienced reader and you can differentiate between the false positives and the true positives, then you will increase your cancer detection rate significantly.
Okay, and Tusen tak, Dan from Norway. Thank you very much, Dan.
Very well done.
Got to get that in. I think thank you very much for all the people that submitted questions. We really appreciate that. Just while we're winding up, just want to thank the Canon Medical team for everyone who helped put this on, and particularly our marketing team, Amy Yongan-Leenan, Tara Shaw and Dana Lee, also too from Ultrasound, Siobhan Noy, and our big boss, Jason Cotter. And I'd like to especially thank Beth Knight for producing and setting up this webinar. I'd like to thank everybody who's joined us for this webinar. We really appreciate you coming on. And also to finally, big thank you to Professor Mary Rickard. Thank you for sharing your experience, knowledge, and your presentation. It was fantastic, and taking the time to answer all those questions. We really appreciate it. I know that you've just had a big conference recently, Mary, but there's nothing in the near future where people can catch you?
Nothing just in the short term, but thank you for asking.
That's okay. So look out for Professor Rickard if you're at a conference. Hopefully you'll be able to catch her again. And with Canon Medical webinars, we're planning another Australia, New Zealand, worldwide webinar on vascular in Q2 of 2026. So until then, from me, Beth Knight, and Professor Rickard, thank you again. We wish you a very good evening. Thank you.